So the second case I'd like to highlight is also another tibial artery case. This was a 76-year-old male with high blood pressure, high cholesterol, and inflammatory bowel disease who had previously undergone a right lower extremity balloon angioplasty and stenting at an outside hospital, who represented with severe ischemic rest pain of the right foot and some associated skin fissuring. His preoperative vascular lab studies demonstrated diffuse high-grade instant restenosis involving the superficial femoral artery with flat waveforms at the ankle and ABIs and TBIs that were unobtainable, as you can see here. Preoperatively, his foot was grossly discolored, indicating severe ischemia of the right foot with diffuse purple discoloration throughout. The initial arteriogram was performed through a contralateral femoral access approach. This demonstrated diffuse disease within the proximal superficial femoral artery. The superficial femoral artery was occluded. There was reconstitution of the popliteal artery behind the knee, but then below the knee had severe calcified diffuse tibial artery occlusive disease. There was a patent stump of anterior tibial artery, which then was occluded beyond this, but the DP, posterior tibial, and distal posterior tibial artery were all occluded with no significant reconstitution, and the perineal artery was the only meaningful tibial artery runoff distally. On this initial arteriogram, we could not identify any flow into the foot. The occluded superficial femoral artery stents were easily crossed with a crossing catheter and a glide wire. We were then able to perform balloon angioplasty on the SFA pop segment using a 4mm balloon to simply establish a flow lumen. We then selected the anterior tibial artery with an 014 wire and a crossing catheter. I was able to advance the 014 wire through the anterior tibial artery and into the foot. I was not able to cross the occluded segment with a crossing catheter, and therefore elected to proceed with the Shockwave Javelin catheter to cross through the occluded segment. So I was able to successfully cross the anterior tibial artery occlusion as well as the dorsalis pedis artery occlusion while advancing the Shockwave catheter over the 014 wire and simultaneously delivering pulses. As you can see from the images here, we were able to traverse the entire segment of the anterior tibial artery occlusion and advance the catheter well into the foot through the dorsalis pedis artery into the metatarsal segment. The immediate post-Javelin arteriogram demonstrated an established flow lumen with still significant disease, but you can see compared to the pre-treatment arteriogram that there was now a flow lumen through the anterior tibial artery for us to work with. We then followed this with a 2.5mm angioplasty balloon on the dorsalis pedis artery and distal anterior tibial artery and treated the proximal and mid segments of the anterior tibial artery with a 3mm angioplasty balloon. The completion arteriogram following definitive therapy with angioplasty demonstrated a widely patent anterior tibial artery with brisk flow and now clear flow into the foot through the patent dorsalis pedis artery and significantly improved flow compared to what we were looking at pre-treatment. The previously occluded superficial femoral artery stents were treated with self-expanding stents, and the completion arteriogram demonstrated brisk flow throughout the right lower extremity and significantly improved flow into the foot through the anterior tibial artery and dorsalis pedis artery. And compared to pre-treatment, where we had diffuse discoloration of his foot and severe ischemia, immediately post-procedure, his foot pinked up, appeared to be much more well perfused than when we started, and he had robust Doppler signals that were very easily audible in his foot. In the recovery room, he had complete resolution of his rest pain, which is a very, very nice clinical result once again.